evening to all of you, and I hope all of you are doing well, including your family members. Everybody is doing well and happy. So we will take our session today, but I would like to request you to that most of you would like participate more actively, and please feel free to put up your questions in the chat box, because directly we can't take it. So if you put your questions in the chat box, then we can take up some of those questions. Whatever your personal doubts are there, we can take up some of those questions, and we can clarify those questions. Can be like straight away in this session itself, we can get them clarified. Okay. So without wasting time, let's get going. In today's session, we will be discussing more of an approach to clinical vignettes. Okay, so here I will not be talking about any specific chapter, any specific portion, but we will be seeing just how to approach and a clinical scenario based question. So that is called as a clinical vignette, and we will go and see. Before that, one thing that I would like to put into all of you is that please read proper textbooks. That is my only request to you, juniors, that please read a proper textbook. Okay, don't go for those guides and those question answer books straight away from the beginning. If you follow those books, then the issue will be that your concept clarity will not be there. You will not be very clear with your concepts. And as all of you are aware, there is something called as NEXT that is coming up, where eligibility test, where you will all have to clear in order to get your internship and participation and your next level of professional participation. So your concept needs to be very clear. See, once you are clear with your concept, any clinical scenario is easy to approach. Okay. So first, in our subject, what we need to know, or rather in any subject, whether you are reading a textbook of medicine or surgery or pathology, whenever you take up any disease, for example, you take about breast carcinoma, first, what are the things that you are going to find? First, you're going to find something about normal. Then what are the inflammatory non-neoplastic conditions? Then you will find something about neoplastic conditions. You will find about diagnostic criteria. You will find about the pathogenesis of disease. You will find about the evolution of disease. You will find about how the disease is diagnosed. What are the modalities to diagnose such a disease? And then in the end, you will know how such a disease is treated and what is the prognosis of such a disease. Okay. So first, for that matter, any disease process, we need to have a definition. When we say that this patient is having such a disease, we don't have a hard definition for all pathological process, but there are certain diseases, like say for diagnosing a diabetes, we need a blood sugar of more than 126 on more than 2 occasions to diagnose somebody as diabetes, right? So for everything, there will be a diagnostic criteria, or like when we can diagnose such a disease. Then the epidemiology. Now, this is again very important. Remember, all this why I am talking, because when we will be going to our clinical scenarios, all these points again I will be highlighting. So when you prepare for a disease process, you need to know the epidemiology. Now, how this is important? Certain disease will happen in pediatric patients, like say, for example, leukemias or lymphoid leukemias are more common in pediatric patient. When we talk about thyroid carcinoma, they are more common in females. When we talk about lung carcinomas, they are more common in males, because males are more likely to be smokers. So that is how the epidemiology varies. Okay. Then comes the causes or etiology. Now, when you read all kind of pathology, they will have certain causes or predisposing factors which cause this disease. Like, for example, if you have a gastric ulcer, you have a H. pylori. Now, somebody has a lung cancer, you will mostly find smoking as a predisposing factor. I am not saying always. Even without H. pylori and smoking, somebody can have a gastric carcinoma and lung carcinoma. But these are some common. Like when we talk about carcinoma cervix, human papilloma virus is the commonest etiology. So there will be some causes for it, and that we need to know. Then comes how the disease happens. Like suppose when we talk about carcinoma cervix, first there is a HPV infection. HPV infection happens at young age or during early sexual exposure. After that, how the disease evolves, how this HPV, high-risk HPV DNA gets integrated into the human DNA, how the E6, E7 proteins function, how they modify our oncogenes and proto-oncogenes, and what is the outcome. Okay, so that is what is called as the pathogenesis. Then once we know how the disease happens and the changes happen at molecular level, there will be some changes happening at phenotypic level. Like when the tumor is very small, we may not notice a swelling. But once the tumor starts growing, we will start noticing a symptom. For example, if a small tumor is there in the pancreatic head, you may not have jaundice. But when the same small tumor starts growing to a bigger size and obstructs the CBD, then it can result in obstructive jaundice. That is when it will manifest clinically. Same like when there is a dysplasia in the cervix, we may not have gross changes, right? But when this dysplasia progresses to invasive carcinoma, then the lady may have a ulceroproliferative growth with foul-smelling discharge, postcoital bleed. So those are clinical features. Then we need to know what is the morphology of those features, and for that we need to know certain diagnostic modalities. Okay, as a clinician, as a pathologist, more so as a clinician, you must know which diagnostic modality to choose for which kind of disease. Now I will give you an example. If there is a lung tumor, should we do a flow cytometry? You all know the answer, right? Flow cytometry is done for hematololymphoid malignancies. For a lung carcinoma, what can we do? We can do a sputum, we can do a pleural effusion cytology, we can take a biopsy from the lung, we can take a FNSE from the lung. So these are certain diagnostic modalities. And you must know which type of diagnostic modality to be used. So I will ask you one question, just think over it. If somebody has a thyroid swelling, which modality would you choose for a thyroid nodule? Okay, so just for your thought to stimulate you, we will answer it later. Now comes the management. Now, if you go for any disease process, in the end, there has to be a treatment for such a disease, right? Now, how the management varies. If we diagnose something as a lymphoma, the treatment will be chemotherapy. Whereas if we diagnose something as a sarcoma or carcinoma, the treatment will be surgical management. If we diagnose something as tuberculosis, the treatment will be ATT. So the management will vary as per the diagnosis. So diagnosis is very important, and as a clinician, you must know which diagnostic modalities to be chosen. Then obviously, after you have managed the patient, then comes the prognosis and prevention. Like say a patient of a pancreatic carcinoma and a patient with a papillary carcinoma. Who is likely to have better prognosis? Obviously a papillary carcinoma of thyroid. Papillary carcinoma of thyroid has very good prognosis as compared to a lung carcinoma or as compared to a pancreatic carcinoma, which has a much worse prognosis. And prevention, how can we prevent them? Like say I spoke about carcinoma cervix. Now you may get a question, how can you prevent carcinoma cervix, right? You must be wondering how we can prevent. We can prevent it through early screening as well as vaccination. Now HPV vaccination. As well as for hepatitis B, we have a hepatitis vaccination, which will also prevent us from having hepatocellular carcinoma in the long run, or as a complication of hepatitis and cirrhosis. So now you see, we need to know definition, epidemiology, etiology, pathogenesis, clinical features, diagnostic modalities, management and prognosis, because the question can be relating to any one of them. And we will be discussing in our subsequent session, you will see how each of the parameters can be important. So when you are preparing, you just have to read, not just like from a guide or some question answer book like about one tumor. You have to know to approach a tumor or approach a pathology in that system. And a proper textbook only can tell you whether you read a Robbins or you read a Harsmohan, or for that matter, you read Harrison. Any textbook, the textbook will tell you how to approach a system and what are the proper diagnostic modality, how to properly diagnose it. Okay, so with that note, we will go to our clinical vignette. So what is a clinical vignette? It is a report. I put it very simply. It is a report of a patient, okay, put together or summarizing the present complaint, relevant past history, physical examination findings, investigation, if any investigation has been done, and if any treatment has been given. So all have been put together. Now, in your exams or during your NEET or your MBBS exams, you will have such clinical scenario-based questions where the question can be MCQ type or the question can be of a long question type that we will discuss. So this is how a clinical vignette, it will contain about present complaint, relevant personal history, physical examination findings, investigations, or whatever is relevant data, and therapy. So let's see how a clinical vignette look like. Now, here comes a 40-year-old multiparous woman. Now, every information in a clinical scenario is important. She is 40. She is multiparous. Okay. She presented with, I have told you present complaint, foul smelling white discharge. Foul smelling white discharge par vaginum for 3 months. Okay. On eliciting certain history, she gave history of postcoital bleed. Means typically after coitus, there is bleeding. And she also gave recent unexplained weight loss. Remember, unexplained weight loss favors malignancy, favors tuberculosis, favors HIV. We will come to that. But remember, she gave history of unexplained weight loss. She also gave history of multiple sex partners in the past. So many things have been put into it. Okay. And on vaginal examination, there was an irregular and unhealthy cervix. Okay. So this is how a clinical scenario would look like. And I hope you have made out what is the answer to this question. We will be approaching to the same question through different ways in the subsequent slides. Now, in any clinical vignette, what are the things that you are going to find? First is a stem. Like I showed you, whatever I showed you as a clinical vignette is the stem. And in the stem, you will find certain points that will help you. They are called as helpers. Then certain points that will guide you towards certain disease, that is guiders. And then there will be certain things called as clinchers. And these clinchers are lab investigations and reports which will help you to confirm or narrow down your diagnosis. Okay. So that was about the stem. And that stem will be followed by a question. Now that question can be a long question based, or that question can be a MCQ relating to pathogenesis, relating to mutation, relating to diagnostic modality, relating to prognosis, relating to therapy. It can be relating to anything. Okay. You, in a multiple choice, you will have more than one options which you have to choose from. So what are these helpers? Now these helpers, they provide some clues. Remember, all these points are important when you are approaching. They provide some clues. Okay. So what are these helpers? Demographic data. Like I told you, age, sex. We know certain tumors happen in certain, like a thyroid carcinoma more common in female, pancreatic carcinoma more common in male, lung carcinoma more common in male. More doesn't mean it is exclusive. What I'm telling is incidence is more compared to female. Okay. So demographic data. Now ethnicity is also important. Which country we live in, which part of the country we live in a bigger continent, which part of the subcontinent we live in, and certain things like, for example, I'll give you an example, a basal cell carcinoma. Now, basal cell carcinoma is caused by UVB radiation, right? And it is caused, it is more common in white people as compared to Asian population. Okay, just an example. Then we have certain comorbidities and risk factors. Like in the previous scenario, we saw the risk factor was multiple sexual partner, multiparous lady, those were risk factors. Okay. So you will have certain comorbidities. Now comorbidities, like suppose you can have hypertension, you can have diabetes, you can be having a malignancy, you can having a chemotherapy. Okay. That is all called as comorbidity or risk factors. Now why risk factors? Because, for example, I will give you a scenario. Now a patient who has hypertension and diabetes is more likely to have atherosclerosis as compared to a patient having only hypertension or only diabetes. Okay. So hypertension and diabetes both have a synergistic effect in causing atherosclerosis. So these comorbidities and risk factors, right? So these helpers have very poor specificity. Now, if I tell you it's a 45-year-old lady, will you be able to make out? No. If I tell you she has a foul-smelling discharge only, will you be able to make out the disease? No. So these have poor specificity, and they have to be connected with the guiders as well as clinchers. So what are these helpers? Let's see. Whenever we have obesity, hypertension, diabetes, these things are given in a question, you have to think of metabolic conditions or cardiovascular complications like atherosclerosis, AMI. Okay, whenever your atherosclerosis or AMI related MCQ questions will be there, you will always find guiders like obesity, hypertension, age will be like more than 40, 45 years. Smoking may be one of the points that may be provided. Okay. Then you have hypertension and diabetes. Okay. When you have hypertension and diabetes, now you know hypertension and diabetes, they involve most of the organ systems in our body. So a hypertension can cause a stroke. So you can have CNS manifestation. Diabetes also predisposes to more stroke. Okay. Some serious complications, you can have atherosclerosis, you can have a myocardial infarction. Both hypertension and diabetes lead to that. In the ocular, in the ophthalmology, we can have, because of diabetes, you can have proliferative retinopathies. Because of hypertension, you can have hypertensive retinopathy. In the kidney, again, you can have nephropathy also related to hypertension and diabetes. Okay. So whenever these things are given, these are helpers, these are guiders and helpers, which will not confirm, but they will lead you to certain direction. Whenever there is a history of HIV or immunosuppression means a patient who is in chemotherapy. So whenever these history are there, you will have to think of opportunistic infections. Because whenever a patient is having HIV, your CD4 counts will go down. Whenever immunosuppression is given, bone marrow counts will go down. So their pancytopenia will be there. So there is a chance of opportunistic infections. In addition to that, in HIV, you can have certain AIDS-defining malignancies. Like, for example, let's talk about carcinoma cervix. Carcinoma cervix is a AIDS-defining illness. Or you can say in HIV patient, the carcinoma cervix is more likely to happen because of HPV as compared to non-HPV females. Other things like CNS lymphomas. Now, CNS lymphomas are very common in HIV patients. Okay, they can happen in other patients, but they are more common in HIV. So if the history of HIV is given and there is a chance of a lymphoma with other clinical history, then I can put them together and correlate them. Now comes the guiders. Now guiders are the most important part of the step. These guiders are the clinical features that are signs, symptoms, duration. Now duration is acute and chronic. Okay. If something is of a short duration, we say acute. If something is of a long duration, we say it is a chronic. Like say for example, tuberculosis. Tuberculosis is a chronic inflammation, whereas any suppurative, suppose say we have a suppurative folliculitis, that is just a acute inflammation. Okay. Signs of inflammation will be there in acute, whereas in tuberculosis, we do not have signs of inflammation. Now the symptoms can be cough, fever, diarrhea, edema, jaundice. Each one of them we will discuss. But remember, now whenever we talk about cough, just by saying that it is cough, you cannot think that whether it is now cough can be because of GERD, cough can be because of lung, cough can be because of heart ailments. Okay. So cough is there, doesn't mean again that you will have a respiratory. But if I say cough with the sputum production, then we can think that it is likely to be respiratory. See how the things change. Okay. So guiders will help you to narrow down, but they will not confirm. Okay. Like ascites, hepatosplenomegaly, proteinuria, we will see each one of them, how they are helpful. So these guiders will help you to suspect. Okay. They will help you to still narrow down as compared to helpers. Helpers will just indicate certain things. Guiders will still lead you towards something. So they have got much better specificity as compared to the helpers. Okay. So the final diagnosis cannot be made from guiders, but they can help you to narrow down on certain diseases. Now, for example, whenever you see a case scenario where ascites and edema is spoken about. Now, ascites and edema is because of hypoproteinemia, and that hypoproteinemia can be because of liver disease or can be because of kidney in nephrotic syndrome. Okay, when the kidney is leaking proteins, proteinuria is there, or liver failure is there, liver is not synthesizing, so they can lead to edema. right? Heart failure, pumping failure is there. So peripheral accumulation will fluid happen. So there will be edema. So by seeing edema, can you tell me whether the problem is in the heart or kidney or liver? We cannot say. Clear? Now comes jaundice. Now jaundice we know increase or it's a state of hyperbilirubinemia. By seeing jaundice, can you tell me, by seeing a jaundice patient, can you tell me whether it is a pre-hepatic, it is because of hemolysis, or because of hepatic? Hepatic means you understand, I hope, hepatitis. Okay, hepatitis, or post-hepatic, like it is because of obstruction. Or like I gave you an example of pancreatic carcinoma leading to obstructive jaundice. So by seeing jaundice, you cannot make out whether it is pre-hepatic, hepatic or post-hepatic, but we will see after the clinchers or after the lab investigations are done, how the same thing will help to confirm one specific disease. Similarly, whenever fever is there, don't just think that infection is the cause of fever. It can be because of inflammation, it can be because of neoplastic process. Now, you should not confuse infection with inflammation. They are totally different. Infection can result in inflammation, but all inflammation are not because of infection. Why? Because inflammation can be because of autoimmune disorders also. Okay. Now, weight loss. I have already told you that if a patient is looking very cachectic and you see a patient very cachectic, very thin built, weight loss is there, unexplained weight loss, what are the common things that will come to our mind first? First, we will think, is the patient having tuberculosis? Very common. Tuberculosis in our country, chronic infection. Okay. Then chronic inflammation, like your autoimmune disorders, connective tissue disorders, they are very commonly resulting in weight loss and the patients will be very thin built. Then in the gastrointestinal tract, you can have malabsorption because the nutrients are not absorbed properly. That can lead to weight loss. Or finally, the malignancies. Now, tumors, whenever they are in advanced stage of malignancies, most of these patients will be very cachectic or they will have a significant weight loss. Now, petechiae. If somebody has a rashes or like bleeding spots in the body, then that can be because of thrombocytopenia, that is decreased platelets, or it could be because of damage to the vascular vessels, that is vasculitis, or inflammation of the blood vessels. Okay. Now, just by seeing petechiae, can I say that is because of thrombocytopenia or vasculitis? Again, remember, I cannot say. But if I do a peripheral smear and see that the platelets are reduced, I can think that it is because of thrombocytopenia. Or I do a biopsy and in the biopsy, I find that the vessel wall is inflamed and we have features of vasculitis, then I can confirm that this petechiae purpura is because of vasculitis. Similarly, hepatosplenomegaly. Remember, these are clinical features that you need to appreciate. Hepatosplenomegaly. So liver is enlarged, spleen is enlarged. And what are the common causes? We can think of infections. What infections? Commonly malaria, kalajar. Okay. So the subacute bacterial endocarditis, these can lead to hepatosplenomegaly. In addition to that, you can have hematolymphoid malignancies like leukemia, lymphoma, portal hypertension, of course, can cause hepatosplenomegaly. So again, until and unless you do the lab test, these tests, like these findings will not help you to confirm the disease. Now, lymphadenopathy. Lymphadenopathy means significant enlargement of lymph node. Now, lymphadenopathy can be because of infections, can be because of tuberculosis, can be because of autoimmune disease, can be because of malignancy, metastatic, carcinomas, lymphomas, all kind of benign and malignant pathology can involve the lymph node. So by seeing the lymphadenopathy, we can narrow down, but we cannot exactly classify which disease. Similarly, chest pain, just like cough, seeing a chest pain, you can't say whether it is from lung or that chest pain is because of heart or that chest pain is coming because of GERD or gastroesophageal reflux. But simple, if there is a chest pain in a patient who is obese, who is having hypertension, who is having diabetes, along with it, you do a ECG or you do a TROP-T and TROP-I investigation. And if TROP-T and TROP-I are elevated, then you can assume that the patient is having myocardial infarction. Okay. Now, proteinuria. This is another very important thing. Very frequently, you will find in different clinical vignettes that patient has proteinuria. Now, proteinuria simply tells you there is kidney involvement. Now, proteinuria doesn't tell you which disease. The kidney can be involved by inflammatory pathology, non-neoplastic pathology, neoplastic, so many pathology, right? So, if you have proteinuria along with glycosuria, can you name the condition where there will be proteinuria as well as sugar in the urine? It is diabetic nephropathy. Okay, glycosuria comes only in diabetic patients. So diabetic glycosuria along with proteinuria will tell you that it is likely to be a diabetic patient. Okay, then if you have proteinuria, only proteinuria, then it can be nephrotic syndrome. But if you have proteinuria with hematuria and active sediments, then it is likely to be a nephritic syndrome. So when we talk only proteinuria, the diseases are different. When I say proteinuria with hematuria and active sediments, you have to change your differential diagnosis. You have to think of nephritic syndrome or nephritic diseases that result in inflammation. Now, what does this active sediments mean? This active sediment simply means that you will have RBCs, WBCs in the urine. Normally, they are not present. Now, the third component are clinchers. Clinchers means they will help you to confirm. So you will have to keep an eye on the guiders, the helpers, the guiders, as well as the clinchers. Okay. Now these clinchers, I have already told, they are more specific and they will help you to rule in or rule out any disease. Like say, a biochemistry parameter. I have already explained, if there is a jaundice patient, you do the bilirubin level, you do the liver function test, then you will know whether that jaundice is because of obstruction or that jaundice is because of hepatic cause or that jaundice is because of pre-hepatic cause. Clear? Then TROP-T and TROP-I have explained. Then you do certain serum markers. Like suppose a patient, a 60-year patient presents with bladder outlet obstruction. Now, whenever there is a bladder outlet obstruction, that problem can be because of bladder or that problem can be because of another organ situated just below the bladder, that is prostate. Clear? Now, can you tell me, if I tell you there is bladder outlet obstruction, can you tell me what is the cause of that? You cannot. Or what is the disease process? But if I tell you the PSA level is elevated or prostate specific antigen level is elevated to 6, can you tell me in a 60-year what could be the cause? It could be because of prostatic carcinoma or hyperplasia. Come on, think. It is hyperplasia. But same clinical scenario, 60-year-old male with some symptoms of bladder obstruction, but I tell you that the PSA is a 12 or 15. What would you think of? You will narrow down to prostatic carcinoma. Clear? So that is how these clinchers help us. Now, similar, that was about a certain biochemistry reports. Now we talk about certain pathology reports. Okay. Now, in pathology, how they are helpful. Now, if a lung tumor is suspected, we can do FNSC or biopsy, and then we can do IHC markers to confirm. But remember, again, biopsy is not necessarily always a confirmation. Like, for example, you have taken a lymph node biopsy and it is reported as granulomatous inflammation. Now, can you tell me which disease am I talking about? Do you think it is tuberculosis? Yes, of course, it can be tuberculosis. But there are other granulomatous conditions also. Like, for example, sarcoidosis, for example, leprosy is also a granulomatous inflammation. So when we say only granulomatous inflammation, that is not enough. But we have to say whether it is a necrotizing granulomatous inflammation, plus we have to do certain special stains like acid fast stain. If it is positive in a necrotizing granulomatous inflammation background, we can say that it is tuberculosis. Otherwise, again, granulomatous inflammation is a broad category. You cannot specify which disease we are talking about. And remember, the treatment is different for sarcoidosis, the treatment is different for leprosy, the treatment is different for tuberculosis. So you have to be very particular that which disease are you trying to diagnose so that you can give the specific therapy. Now, whenever we have any hematological related abnormalities, we all are a lot dependent on the peripheral smear. So if you have a patient with jaundice and you examine the peripheral smear showing hemolytic anemia, then it becomes easy. You can say probably it is a prehepatic cause. Okay. Similarly, when you have a leukemia or you are doubting whether a patient has a leukemia or a leukomod reaction, you can run a flow cytometry and then you can confirm whether it is a leukemia or it is a reactive condition. Got my points? So the next is radiology. So the biochemistry, pathology and radiological reports always help to clinch certain diagnoses. Now, radiology, you must know two things. I would like to highlight here two things. Just TIRADS and BIRADS. Now, TIRADS is a scoring system used for thyroid. You can read more detail about it. And BIRADS, B for breast, T for thyroid. So BIRADS is a scoring system that is used for categorizing lesions, radiological lesions of the breast. Okay. So if somebody will tell BIRADS 5, that means it is more likely to be malignant. If it is BIRADS 2, that is more likely to be benign. Again, remember, radiology reports are not confirmatory. They have to be confirmed with tissue diagnosis. So clinchers are the ones that will help you to confirm the diagnosis. So that was about how to approach. So you must know so many things in order to approach. Now we will take on the same question that I had presented to you and how it can come. If you are an MBBS student and you are going to appear your MBBS exams, whether it is a gynae exam or it is a pathology exam, whatever exam, you can have a scenario like this, right? So the same scenario I have told, and what questions you can give. If it is a long question or it is your MBBS exam, what you can get a question like this. What is your diagnosis and what is the reason for your diagnosis? I hope all of you have got the reason. Now the diagnosis here, I am talking about a 40-year female, foul smelling discharge, and she has history of postcoital bleed. These are very typical. Unexplained weight loss. These are very typical of a malignancy. And what malignancy are we talking about? Because she has foul smelling discharge, she is likely to be having a cervical carcinoma. And there is a significant history also, multiple sex partners. We know multiple sexual partners means more likely to have HPV infection. And on examination, there was an irregular, unhealthy cervix. So probably she has crossed the dysplasia stage and she has gone into a stage of infiltration or carcinoma cervix. Okay, reasons all I have explained. Now, briefly describe etiopathogenesis. You will have to talk about smoking, multiple sexual partners. You will have to talk about HPV infection, how HPV 16 and 18, how they are involved, the pathway or the molecular pathway. And then you have to add a note on its diagnosis and prevention. Remember, most of you are asked about diagnosis means it has to be a pathological investigation which confirms or diagnosis. You can't tell CT scan, PET scan. Yes, they are done, but they are done for staging. They are not done for diagnosis. For diagnosis, you will have to do either a pap smear or you will do a pap smear and followed by a biopsy. You will do a HPV testing. These are certain modalities that you will adopt. Okay, so the same scenario in a long question way, this is how you will get it. Now, the same scenario has been given as a MCQ. Okay, so here the same scenario, the last point is what should be the best diagnostic modality for confirmation. This is the kind of thing that you will get in a MCQ, and you have 4 choices here. Okay, so now this, sometimes I would like to tell you that when you are approaching a clinical vignette like this, at least read the last line first. Read the last line first. That will tell you a lot of information. I am not telling that don't read the other lines. I am just telling you, read the last line first so that you will know what the question is asking, whether it is asking the treatment modality, whether it is asking about the diagnostic modality, whether it is asking about the prognosis. So about the genetic modality, what is the last line? Okay. And then you go on to read the question. So here, what is the best diagnostic modality for confirmation? Now, after reading the question in detail, we have understood that it is a carcinoma cervix. So, should you do a cervical pap smear? Should you do a biopsy? Should you do a exfoliative cytology? Should you do a fine needle aspiration cytology? Which one should you do? Just think which is the best modality that can be applied here. So, the best modality is biopsy because already it has gone into a stage of carcinoma. So this pap smear, which is usually done for screening dysplasias, not screening malignancy, screening for early stage of cancer, that is dysplasia. Okay. So now this patient has crossed that stage. So there is no use of doing a pap smear. And remember, pap smear is a screening test and we have to do a biopsy for confirmation after a abnormal pap test. So here the most appropriate would be cervical biopsy. We don't do FNSE in cervical lesions. We do FNSE in superficial and other visceral lesions. Exfoliative cytology is nothing but other type of pap smear is also a type of exfoliative cytology. So we don't do scrape smear. If we take a scrape, we can do a pap, but we cannot confirm. So we have to do a biopsy. Now it is question time. And we will go to certain clinical scenarios. System-wise, I have set up some clinical scenarios. That is very important. These are small questions, but we will test out how well you have understood our session and how well you have understood those chapters which you have read through. Now here comes a 22-year-old female with a firm mobile lump with a family history of breast carcinoma. Now in this young female, she is 22. The lesion is firm mobile, okay, and she has a history of maternal breast carcinoma. Her mother had a breast carcinoma. So what do you think this is likely to be? Do you think this is likely to be a carcinoma? Yes, it is possible. But you remember, this is a 22-year female with a firm mobile lump. So in a very young female with a firm mobile lump, the first thing that should come to your mind is a benign breast tumor, that is fibroadenoma. Yes, she can have a carcinoma. I am not saying that I am 100% sure, but we have to do certain modalities. So here the next question will come. How will you confirm that she has a benign or a malignant breast lesion? How will you confirm? We can do triple test. First, clinical. Clinically, it's a mobile lump, likely to be benign. We can do a FNSE. We can do mammography. So all these things together will help you to diagnose whether it is a benign or malignant breast lesion. Now here comes a 35-year-old female with bilateral lumpy, bumpy breast with history of maternal breast carcinoma. See, I have formulated this just to give you, to create a little bit of confusion so that you are thinking, okay, so family of breast carcinoma is there. But she is a middle-aged 35. Can a 35-year-old have breast carcinoma? Yes, of course. Nowadays, breast carcinomas are diagnosed at much earlier age, so she can have. But she is having bilateral. To have a bilateral carcinoma is less likely. I'm not saying no, but less likely. And she has multiple lumpy, bumpy breast. Okay, she has a lumpy, bumpy feeling. So this complaint is typical that of fibrocystic disease. Okay, so you have to remember, when it is bilateral, lumpy, bumpy breast in a 35-year-old female, it is more likely to be a fibrocystic disease. Malignancies do happen bilaterally, but they are rare or uncommon. Now here comes a 47-year-old female with breast lump and axillary lymphadenopathy. She had history of maternal aunt with breast carcinoma. So there is a family history, so that is very significant. She is 47-year-old. Can you tell me which age group usually breast carcinomas happen? Most of the breast carcinomas happen in the age group of 40 to 60 years. Okay. So she is 47. So yes, she's in that age group. She has a breast lump, which we need to examine whether it is mobile, whether it is fixed. But the other significant finding what is mentioned here is axillary lymphadenopathy. Now, whenever there is a breast lump with the axillary lymph node in a 47-year-old female, you will have to think of a breast carcinoma. And why this lymphadenopathy is significant? Because it could be because of metastasis. Clear? So whenever there is a tumor with axillary lymphadenopathy in a scenario, you have to think of metastasis as a possibility. And so this breast lump is likely to be benign or malignant. This lesion is likely to be malignant. So she is likely to be having a breast carcinoma. Now, same scenarios can be given with various type of questions. A breast carcinoma case and a prognosis may be asked, the staging may be asked, the good factors and bad factors may be asked, something relating to that. Okay, so you have to know all about it. Now we will take up some questions from the ovary. Okay, so a 12-year female with a left solid ovarian mass. Now everything here is important. Whether I'm telling solid, whether I'm telling unilateral, whether I'm telling bilateral, what is the age, very important, right? So which tumors are common? Do you think in pediatric patients, which she is a 12-year girl, of course she's a pediatric patient. So which tumors do you think are more common in pediatric ovary, or which ovarian tumors are common in pediatric patients? So they are germ cell tumors, and on most occasions they are solid. But teratomas can be cystic, right? But whenever we are given a history of 12-year female with a solid or cystic ovarian mass, you have to think of teratoma, or you will have to think of germ cell tumors. Next comes a 25-year-old large cystic ovarian mass. So it is cystic, it is large, and the young age, that is 25. Now we know that if you read ovarian tumors, if you read a textbook, okay, a chapter in a textbook where we are talking about ovarian pathology, we know that the benign neoplasms happen at younger age, the borderline happen as little higher, and the malignant ones happen at a still higher age group. So here it is a large cystic ovarian mass. So what it is likely to be? It is likely to be a benign cystic ovarian tumor. Now it can be a serous tumor, it can be a mucinous tumor. How will we confirm that? Can we confirm it from this history? No, we cannot confirm it from this history. For that, we will have to do the histopathological examination. Okay. Comes the third question. 55-year-old female with a large solid cystic ovarian mass and ascites. Now here, the age is gone to higher side. I told you that malignancies happen more commonly in the higher age group. So she is 55. Okay. She is more likely to have malignant. Again, here it was predominantly cystic, here it is solid cystic. Remember, when it is solid cystic, it is more likely to be malignant or like more towards malignancy rather than towards benign. Not always, but it is. Okay, so it is more likely to malignant. And this ascites, what does this ascites say? That this tumor is more likely to be malignant and the tumor cells have already spilled over into the peritoneum, resulting in ascites. Now, can you say what type of tumor? Now, you may say, what you may get MCQ. What non-diagnostic or non-invasive test can be done to confirm that this is a malignant tumor? Or what type of tumor? Can you say which markers can be done here? So, non-invasive tests are serum markers. A non-invasive, I mean, say, you will not need a surgery or a biopsy. You can take some blood sample and do a test. So, what test can you do? You can do a CA-125. So if CA-125 is elevated, so that, see how the helpful tumor markers are helpful. So if I would have mentioned here the patient has a very high CA-125, straight away if you tell me that thing, I will tell you that this is a ovarian serous carcinoma. Okay, that is as simple as that. Now if I tell you same history with ascites and I tell you that instead of CA-125, I will tell you the beta HCC is elevated or alpha fetoprotein is elevated, then what will you think of? If alpha fetoprotein is elevated, which tumor alpha fetoprotein will be elevated? In yolk sac tumor. And HCC will be elevated in germ cell tumors, that is choriocarcinoma. Okay, so see how the scenario changes according to the information that is provided. So sometimes you may be given such a history and the information may be asked as a question. You may not be given that information. It may be asked what non-invasive test you can do to confirm. We can do a serum marker, tumor marker, right? Then comes a 50-year female with a bilateral solid ovarian tumor with a pleural effusion and history of mastectomy 5 years back. So if you backtrack, then there is a history of mastectomy. Mastectomy is there. So probably she had some carcinoma of breast. Okay, 5 years back. Now there is pleural effusion. So can you tell me the cause of pleural effusion? Whether this will be a malignant or benign effusion? It is more likely to be a malignant effusion. So the breast carcinoma has now involved the pleura, and from there maybe it has disseminated or wide disseminated into the ovaries. That is why here we are having bilateral solid ovarian tumor. Whenever we have bilateral solid ovarian tumor, remember it is more likely to be metastasis as compared to primary. But even primary can rarely be bilateral, especially the serous carcinomas or serous group of tumors can be bilateral. Clear? So see here, you may be asked next question, how the question can change. Here the MCQ can be which specific type of cell you find in this tumor. So it is an indirect question. First you have to know that this is metastasis, and then in metastatic ovarian tumor, which is the cell morphology that we find? It is a signet ring cell. Okay, signet ring cell morphology. If we find signet ring cells in the ovary, we say it is metastatic carcinoma. Clear? See how the question can change. Then we will go to a case scenario in gastrointestinal tract. So here comes a 25-year-old male patient student who is preparing for IS exam with history of peptic disease, for which he underwent an endoscopy, which revealed multiple small ulcers in the stomach. So what is the probable diagnosis? He is young, he is preparing for IS exam, and he has APD, okay, acid peptic disease. He underwent endoscopy, we saw multiple ulcers. Now what do you think is the likely cause? Okay, so let's see it this way. Now multiple small ulcers, first of all, they favor benign. Now how I am going to tell that it is benign? Because I know, I have read books that multiple ulcers favor benign. That is what is the importance of clinical features. That is what is the importance of epidemiology. He is a young patient, less likely to have gastric carcinoma. He is preparing for entrance exam, so he will be stressed. And we know stress is a cause of peptic ulcer. Acid secretion, hypersecretion of acid will be there in stress. He may be smoking. He may be taking some alcohol. We know all students during preparation do that, right? So that is a possibility that he may be having a benign ulcer of stomach or benign peptic ulcer. Now the same, we change it to other way. You see 45-year-old alcoholic and smoker with long acid peptic disease, long-standing acid peptic disease, underwent endoscopy which revealed a large fungating ulcer in the stomach. There it was multiple ulcers, here it is a large fungating. Large fungating again favors malignant. On examination, he had enlarged supraclavicular lymph nodes and anemia. How will you explain that? Supraclavicular lymph nodes, what are they called as? If this patient has a gastric carcinoma, which is likely to have because of the fungating mass, then this tumor could have possibly metastasized into the supraclavicular node. And this left supraclavicular node is otherwise called as Virchow's node. Okay. How will you explain anemia? Just think over it. How will you explain the anemia? Can we explain anemia and what type? Now you may get an MCQ here. What type of anemia is this patient likely to have? Whether it is a iron deficiency anemia, whether it is a megaloblastic anemia, whether it is plus blah blah something. So which one do you think? So he is likely to have a microcytic hypochromic or iron deficiency anemia because of chronic small bleeding from the ulcer. Now gastric ulcers can bleed, gastric carcinoma can bleed, because of which patient can sometimes have even melena or dark black colored stool. That is another history you have to remember. But dark color stool doesn't tell you whether it is benign or malignant, because benign ulcer can also bleed, malignant ulcer can also bleed. But if I tell you supraclavicular lymph node, then that supraclavicular lymph node here becomes a very significant finding, and you have to think of a malignancy, and that ulceroproliferative growth is also favoring malignancy. And he is a alcoholic, he's a smoker, which we know alcohol and smoking are two important predisposing factor for gastric carcinoma, in addition to which bacterial infection causes gastric carcinoma. Recall which bacterial infection causes gastric carcinoma. I have already told it. It is H. pylori. Okay, so we'll go to now some scenarios in the kidney and then we will wind up. Okay, so a 5-year-old male or child having generalized edema with proteinuria. Now, if I tell you edema and proteinuria, where would you think most likely cause is in the kidney? But if I tell you only edema, then you cannot think it is because of kidney or because of liver. Right? So the patient has proteinuria and lipiduria. So here the question can be which disease the child is most likely to be suffering. So what is this child suffering from? Is he suffering from nephritic or nephrotic? First question. That may be a question. So here the child doesn't have active sediments. It is not told. So most likely suffering from nephrotic syndrome. If they would have told protein is more than certain cutoff. So what is the cutoff for proteinuria to say it is nephrotic or nephritic? Can you tell what is the cutoff? It is how much? 3, 3.5, 4, 4.5. So it is 3.5 grams per day. So here the child is likely to be suffering from nephrotic syndrome. And if you ask him what is the most common cause of nephrotic syndrome in a pediatric patient, it is minimal change disease. Okay, so here the patient is likely to have minimal change. Here the question can be anything. It can be directly what the child is likely to suffer from. You can say minimal change disease. Or it can be an indirect question. It may be so asked that what will be the morphology of kidney biopsy in this patient? So it will be looking normal. That is why it is called as minimal change disease. So you may have any, or it may be asked like, is this patient suffering from nephritic or nephrotic? So something relating to that. Okay. Then comes a 45-year-old male with proteinuria more than 3.5 grams per day. Remember, active sediments are not told. That means it is only proteinuria. Now, this patient is having proteinuria significant more than 3.5. So he falls into which category? Nephrotic or nephritic? He falls into nephrotic syndrome. And then there is a biopsy which shows diffuse regular membrane thickening. So what is the patient likely to be suffering? Now the questions can be different. See, the same scenario, if it is a MCQ based question, I can frame it anyway. I may ask you what serum marker you will do. That is an indirect question. Before that, you need to know what is the disease that we are talking about here, right? So what is the prognosis of disease? I may ask you which special stains you will do in such a disease. Okay. So here, proteinuria, 45-year-old male, regular membrane thickening, the patient is likely to be suffering from membranous glomerulopathy. And what serum marker we do for primary versus secondary membranous? We do PLA2R. Okay, you can read about it. I just told you for a scenario. We can't discuss detail of it. Okay. Now, a 55-year-old female with HbA1c of 9.5 and proteinuria of more than 3.5 grams per day. Now, what does this HbA1c of 9.5 tell you? What information do you see? Now, sometimes, remember, other thing, you will have to know what are the normal values. Now, here, if you don't know what is normal HbA1c, you cannot know whether this is increased or decreased. Okay. So, a good clinician or a good pathologist or a good medico will know the values, the lab values, or the exact cutoff values. Okay. So, if you see HbA1c, it is normally less than 5.6. Normal. For a normal person, it will be less than 5.6. So 9.5 is massively elevated. So what does it tell you? That the patient's sugars are likely to be elevated. So the patient is likely to be what disease? A diabetic patient. Okay. Now, there is a proteinuria of more than 3.5 grams per day. So what are we talking about? We are talking about diabetic nephropathy. Right. Now here you may get a question MCQ like this. In this patient, which kidney findings you will get? They will say KW lesions. They will say capsular drop. They will say fibrin drop, something like that. Okay. So then first you have to make out that we are talking about diabetic nephropathy. Then you will have to recall what are the features of diabetic nephropathy, and then only you will be able to answer the MCQ. So remember, these things are not going to happen if you don't read a proper textbook. Your concepts will not be clear, right? And then if you read a guide, you will be always struggling. Then comes a 25-year-old female with proteinuria and active sediments. Now, this is the last scenario where we have talked about a 25-year young female, proteinuria is there, active sediments is there. I have not specified how much proteinuria, but what does active sediments tell you? That she is likely to have WBCs and RBCs. So proteinuria, RBC, WBC. What is she likely to be suffering from? She is likely to be, which syndrome can we put here? We can put her into nephritic syndrome, right? Active sediments means nephritic syndrome. Hematuria doesn't happen in nephrotic. Okay. So nephritic. Now a young female, suppose I give you a little additional history. I may tell you malar rash, discoid rash, she has serositis, she has pleural effusion. What she is likely? She has arthritis. What she is likely to suffer from? She is likely to be suffering from lupus nephritis. Okay. SLE is very common in young females. So SLE, you can have any type of questions relating to SLE in clinical based. It can be relating to gynae, multiple pregnancy loss. In dermat, she can have malar rash, discoid rash. In pulmonary medicine, SLE patient can present with pleural effusion. In neurology, they can present with psychosis. In a hematology lab, they can present with anemia and thrombocytopenia and pancytopenia. So in an orthopedics clinic, they can go with arthritis. In an immunology clinic, they can go with other immunological manifestations. So you can find a SLE patient everywhere. So first you have to know which syndrome you are fitting into, and in that syndrome, which age we are talking about. We are talking about a 25-year and it is a young female. Female are more likely to have SLE, right? Autoimmune disorders are more common in females, very rarely seen in males. So coming to a hematology scenario, here we are talking of a 6-year-old boy who is diagnosed with pneumonia. So the boy is diagnosed with pneumonia. On evaluation, the boy is found to have a WBC count of 1.2 lakhs, hemoglobin of 8 grams, platelet of 80,000. He also has mild hepatosplenomegaly. Now, if you are a good student who has read proper textbook, normal values, you remember, you will know what is the normal WBC count. So just recall what is normal WBC count. Is it normal? It is very abnormal. The normal count ranges from 4,000 to 10 to 11,000. Okay, it goes around 11,000. So here it is 1.2 lakhs. Hemoglobin is also reduced. WBC is increased. Hemoglobin is reduced. Now, what is the normal hemoglobin cutoff for a 6-year child? For a 6-year child, it is almost like close to an adult, right? So if it is a adult, like maybe from 12 to 16 grams, more likely to. So, but 8 grams is a anemia, moderate degree of or moderate to severe anemia. What about platelet count? Is it reduced or increased? The platelet count is also reduced. Normally it is 1.5 to 3.5 or 4 lakhs or 4.5 lakhs. So here 80,000 denotes that it is decrease in amount. In addition to that, he also has mild hepatosplenomegaly. So what does all that tell you? The patient is likely to have a pancytopenia. We have a WBC series, the patient has increased WBC but decreased hemoglobin and platelets. So that again favors a possibility of something abnormal with the WBC series, and in which condition your WBC goes beyond 1 lakh, it is mostly leukemias. Okay, in leukemia, the WBC count will increase and hemoglobin and platelet will decrease because the WBC series precursors will occupy the marrow. So the others will be suppressed. Now, suppose I told you WBC count was normal, hemoglobin was 8 gram, platelet was normal. He had mild hepatosplenomegaly. What would have been your possibility here? WBC is normal, platelet is normal, only hemoglobin is reduced. The child has growth retardation, the child has mild hepatosplenomegaly. So what will you think of? You will think of a hemolytic anemia. See how with small change, how it changes. So you will have to be very sure or thorough with each and every observation, or you have to be observing each and every point that is mentioned in. Now, if I told you the same child had a normal WBC, normal hemoglobin, but only platelet was reduced. So then you will think it is a ITP, idiopathic thrombocytopenic purpura. Okay. And accordingly, the investigations will vary. Now, if you are talking about leukemia, we need to do a bone marrow aspiration, we need to do a peripheral smear, we need to do special stains, we need to do flow cytometry. Okay. If we are talking about anemia, then we need to talk which type of anemia. We will not do a flow cytometry for anemia. Okay. We will do mostly peripheral smear, certain special stains. We will try to see the reticulocyte count. We will see what is the serum parameters for that. Okay. So those are certain things in the peripheral smear, whether we are finding target cells, sickle cells, all those things also we will have to see. Then the last question, a lymphadenopathy question. With that, we will wind up our session. So it's a 23-year-old female who presented with a slow growing level 2 cervical swelling. Young female, level 2, slow growing for a period of 6 months. Now, what does this duration tell you? 6 months is about chronic. Acute means it is days to hours to weeks. But when something goes beyond months, that is usually taken as chronic. On evaluation, it was an enlarged cervical node without any signs of inflammation. Now, this is very important. Without any signs of inflammation. In acute inflammation, what will happen? We will have signs of inflammation. Calor, dolor, tumor, rubor, all those things. Okay. But here, we do not have any signs of inflammation. So, which disease are we talking about? We are talking about a cold disease, otherwise called as cold abscess. So, what are we talking about? We are talking about tuberculosis. And here, FNSE yielded pus-like material. Now, the next question, how it changes, you see. Now, here, if you are an MBBS student, it will be, what is the most probable diagnosis? You will say tuberculosis or granulomatous inflammation. What is the best modality? FNSE, biopsy, ZN stain, you will say. And what will you expect on the morphology? You will expect granulomatous inflammation. But if it is a MCQ, then how the question can be framed? Just see. So, here, on evaluation, it was enlarged lymph node without signs of inflammation till here. Then the question will be, what would is the most appropriate or most probable expectation on a FNSE smear? Lot of neutrophils, giant cells with granulomas. You will find XYZ something, some organism, this, that. So now what will be the expectation? The expectation will be that you will get lot of granulomas along with giant cells and caseous necrosis. Okay. Now, this was an indirect question. See, from this question, first you have to make out that it is tuberculosis. Then you will be able to tick what will be the microscopic finding of tuberculosis. Now, if you see, don't miss out the signs of inflammation, because signs of inflammation will not be there in tuberculosis. So if you have signs of inflammation, you will get pus, neutrophils. But if you don't have signs of inflammation, we are talking about tuberculosis. So in tuberculosis, we have granulomas and giant cells. So if you can make out that this is tuberculosis, but you don't know what will be the microscopic picture of tuberculosis, tuberculosis, again, you will not be able to correctly answer or tick the correct option that is given. Okay. So you see, with the slightest change of history, with the slightest change of question, how the framing of the question changes. Okay. And then you have to be very vigilant, very meticulous in order to approach these questions. I hope you have enjoyed this. This is JIPMER where I work, and thank you so much.